Today's episode is called Hijacked by COVID: Treatment Changes, Delays, and Solutions for Our Breasties. We're here to talk about reliable, relatable, real talk about breast cancer during the COVID pandemic. So, thank you for joining us. And I'm here with my co host and bestie, Dr. Monique Gary. And then we have one of my breasties, one of my favorite breasties here with us today, Jersey Baker. We also have two other doctors joining us in a few minutes. We'll introduce them, Dr. Kathleen Laveau and Laura Bonner Miller. So let's get started, Monique.
Hi, good afternoon, good evening, everybody. I'm Dr. Monique Gary. You are listening to The Doctor Is In. I'm getting ready to start a watch party on my page. Gather your breasties because we are going to be talking about relatable, reliable, and real advice for breast cancer patients, just like Ricky said, during COVID and beyond. So the goal of this conversation is to bring the community to you because we know that everybody is sheltering in place right now. We're all sort of isolated. And we also know that our treatment plans have gotten turned upside down completely by COVID. And so we want to make sure that we provide you with some doctors who can answer questions in real time, who can explain what's going on, who can bring the care, the compassion, and everything that you'd be getting from your support group that you normally would go to. We want to bring it to you. So we are thankful for you joining us today, and we hope you have a good time. We hope you make it interactive. We encourage you to start watch parties on your own Facebook as well as your other social media, and we're gonna bust it up. We're gonna talk with our breasties and get into it. So let's get started. Why don't you, Ricky, introduce our first guest, please.
And I will let her introduce herself. Jersey is an amazing, amazing breastie. She is an angel, and that's really the name of her nonprofit, Angels in Disguise. And she is a metastatic breast cancer warrior with her armor on. And every day she drives at least 2 or 3 breasties to treatment, even in this craziness that we're dealing with right now. And Jersey, you talk. You're so awesome. I love you so much. So I'm so glad you're here with us.
Yeah, tell us about yourself.
Thank you for having me, Dr. Monique and Ricky. I am a 3-time breast cancer survivor. I became metastatic in 2011. I'm ER/PR positive, HER2 negative, and I just live life to the fullest. And every day. And also during COVID, as Ricky said, I'm driving patients, the ones that are able to be seen, who just got out of surgery. I'm driving them to treatment and to follow up with their reconstructions. But with COVID, things have changed a lot. And I usually go inside the doctor's office with them, waiting with them, or if they need me to go into the actual office and talk to the doctor, because as a new patient, you don't understand all of this all of the time. And just teaching them how to advocate for themselves. But with COVID, I have to stay in the car now.
Now, let me ask you this. How do patients find you? Is this just at your local medical center, or how do patients even get lucky enough to have you as an advocate and as somebody who gives them rides? How's that happen?
From social media, and one of the hospitals here, I have 2 nurse navigators that send me referrals after referrals. Susan G. Coleman sends me referrals. I just keep handing out my business cards. I was on the news Friday night here in Charlotte. I was so excited.
It was great.
Just sharing my story. I'm pretty much a one-woman show, even though I have a board. I drive the patients because I understand.
Mm-hmm. And when did you start this organization?
In 2015, Angel in Disguise was born, and this is our new logo on my shirt.
Oh, wow. It's lovely. So you have patients that you are seeing through their treatment journey. So some of them you're taking to their post-op appointments. Is that what you're doing? Some of them are.
So Angel in Disguise, we're not a taxi service. If you are I specialize in breast cancer, but I'll take any cancer patient. If you need to be seen for whatever treatment, surgery, a post-op appointment, if you need to get glasses, if you need to go to the dentist, if you need to go to the grocery store. One patient She just got a new job. She didn't have funding to put her kids in after school. And so I picked them up. I mean, it was like a 40-minute trip a day, but I did that for her because this is what our community needs. And the disparities are huge, and people who live in rural areas, there is no public transportation. And who wants to get on public transportation when you have breast cancer and you're feeling fatigued, tired, in pain, etc.? So
and especially now, it heightens
especially now,
COVID, right? Yeah.
right.
So how has COVID changed the way you interact with breast cancer patients, and then sometimes with maybe their treatment plans? Have you been ready to take them, and then things get canceled, surgeries moved? Have you noticed some real changes in their treatment schedules?
Yeah, so anybody that's scheduled to have a reconstruction, that's been put on hold. Other appointments here have been put on hold till June, follow up. So the only patients that are going right now are the ones that have radiation, chemo, or say they have drains in and they need to go to the plastic surgeon. The plastic surgeon has to see them. Even for myself, I did a virtual call with my oncologist to get my scan results. Some people may not like that, but I was okay with that. Currently, I can't even get my Xgeva shot or my B12 shot. I've been taking my Xgeva shot since 2011. It helps my bones. So now I'm kind of like, I'm not getting the shot. My bones getting weaker.
Have they told you how long that would happen, or how long you can go without that shot, Jersey?
They have not. They have not. And that's a good question that I'm going to ask them. But here in North Carolina, here we're supposed to be opening back up May 8th. So maybe my shots will resume next month.
Wow, May 8th. And what do you think about that?
I know. How are you feeling?
So I know this is crazy, but I say it to everybody. My faith is in God. I survived stage 4 breast cancer since 2011. I'm out here with these patients with COVID. We wear a mask. I'm also an Instacart shopper now, which I love. So, I put my mask on, wash my hands, pray to God, and keep it pushing.
I love it.
You go. Well, it's so funny because we face this craziness all day after being in chemo.
Right.
We were taught to wash your hands and do all the right things and wear masks. And so if someone said to me, "You'll never get cancer, you won't get sick and die if you would just wash your hands and stay home," right? But people are having a problem with that, and it's crazy. But it's that hard, and it's so important. And what you're doing is such an important thing for people that can't take care of themselves. So you are an angel.
Thank you. Thank you.
So how can you transition your services? So let's say, like, when is it over for you, or does that relationship continue? How does that, or are you still figuring those things out?
When is the relationship over with the patient?
Sure, because I imagine it's probably a lot of patients who are looking for you and who are in need. And how do you triage patients and decide when to transition them to family members or kind of get them in their local support groups?
So some patients, and I hate to say this, I felt like one patient was really taking advantage of the situation, like just because she didn't want to get on public transportation, so I had to transition her out. But then there are patients, I have one patient who the nurse tells me all the time, if I didn't take her, she wouldn't go. Like, her family literally looks to me for when her next appointment is. They're calling me and asking me when is her appointment. I take her by myself. They don't even come with me. I undress her. She can't really walk that well, so I'm pushing her in a wheelchair. So I'll probably never leave her. As long as they need me, I'll probably never say no, even though everyone's like, you have to say no. But I just totally understand. I know what it's like to be a patient and to not be able to get there, to miss appointments when appointments are crucial. Even, after I thought I was cancer free after 5 years, I still followed my same surgeon. And then that's how I found out I was stage 4. So I don't, That's a hard question. I don't, unless they say like they don't need me anymore, I'm going to still be there for them. If they call me or text me, I'm going to get them.
I love that. And the reason I asked, I'm sorry, you go ahead, Ricky.
No, go ahead, go ahead.
I was gonna say the reason I ask is because there's only one of you, and I wonder, how do we make it more sustainable? Like, what would you envision this to look like? Because it sounds like to me every city and every town across America could use something and someone like you. You know, how do we get Jersey and Philly? How do we get Jersey
in Jersey,
and Baltimore?
So Jersey is where I'm from. And that's my vision, and I'm not gonna stop. My vision is to have an angel in disguise in Jersey, an angel in disguise in the south part of Charlotte. I do have a board, and they will help me. But I guess someone stepping up and saying they want to do it, because of course it's volunteer. I don't get paid. There's not really a lot of funding, so just to get some funding behind it and someone to say, hey, like, let's start this, because there is a need in other cities.
There absolutely is. I want to, Ricky, you had another comment. Go ahead.
I was just going to ask you, since you cannot go in with your people that you're taking, how are they feeling about that? Are they afraid? Do they have like more fear about the appointments now because they have to go alone? They're so used to having you there, hold their hand. Do you think
I don't think they're fearful, but they have a lot of questions. So, you know, we'll talk about it beforehand, and I'll say, don't forget to ask the doctor X, Y, and Z. Like today, I had 2 ladies with me, and they were going to the same doctor. And, you know, and I was just saying, what's your subtype? And one was like, oh, I don't know. It's just so much information. It's on this piece of paper. And so I just started talking to her, and she said she didn't have any family that supported her. And I just said, sweetheart, you can call me anytime. I told her about nutrition, how important it was. I told her about, before she gets her implant, to really, really study the different types of implants, because these are things that I didn't have. All I knew is this is the implant I'm getting, and this is the kind I'm getting. And I didn't know enough to research it for myself, which is why I guess now I don't have the implant. I explant it. So just, you know, just having conversations with them before and then after. One lady, she'll write them down, and she'll say, oh, okay, I have to ask them that the next time. And then just, you know, constantly talking about it. And they have no problem calling me. I'm like, they'll just call me, and yeah,
I bet.
It's so hard to go by. It's so hard to go by. I mean, I never had to, so. But it's so much.
It's been really interesting. I have to tell you, from the other side of the exam table, you know, as a surgeon, seeing patients and seeing what happens when they're not able to bring their family members, and they're not able to bring their advocates into the exam room and into the conference rooms and the discussions that happen, because you're right. You know, there's so much information. And, you know, I try to give my patients the diagnosis and the information in a sort of stepwise fashion. But once you hear cancer, you know, you might not hear anything else. And then if you hear cancer and you're starting to wrap your head around it, and then you hear chemo, that's it. You don't hear it. And so, you know, it's really a challenging time. And I think technology is helping us some. And there may be some good that's coming out of this technology, you know, with teleconferences and things like that, because we're able to bring people in that may be in different parts of the country. So maybe, you know, family members who live in other places. But it's been really challenging and isolating for patients who are already, you know, feeling isolated. They already feel like, I don't know what I can touch. I don't know what I can do and who I can be around, because my immune system may be a little compromised. And then you throw this virus in the mix, and, you know, everybody's really having a tough time. Ricky, what do you say?
In Jersey, at least they have Jersey to ride in the car with them. Think of it when they go alone, even.
And to prompt them right before they go in the building, right? Because I can't.
Off the ledge driving to chemo in a couple of weeks, just trying to get them to the doctor's office.
Right. You know, I can't tell you the number of times patients have written down their questions, and then as soon as they get in that exam room, it's like you think they were on TV. They're like this.
Right.
And they're completely frozen, and they forget their questions. They forget which page they wrote it down on. They forgot the notebook. They left it in the car, and it just all goes out the window. And so we just start, okay, let's start at the beginning. And then I do a lot of sort of feedback. What did you hear? What do you understand about what's going on? And then let them lead the conversation. But I imagine, it's different all across the country for a lot of patients.
And I'm glad that you said that, because actually some breasties and I on Wednesday nights, we started having what we call Sister to Sister Wellness Wednesday. And every week we'll have a different breast cancer patient call in, and we just talk to them, and, we just let them talk. And then whatever they say, we'll follow up with, their needs. We talk about wellness, we pray, we cry. And last night we had someone from Jamaica.
Wow.
Yeah.
Mm-hmm.
Yeah. Incredible. And then tomorrow I'm starting yoga 7:30 in the morning with one of my breasties, because what it does for me is it pushes me to do yoga, which I keep saying I want to do. And then for her, she's showing everybody, and it's for anybody and everybody, and it's 20 minutes of yoga 3 days a week.
That's incredible.
Good. Yeah.
That's incredible. One of my good friends and one of my breasties, she's not a breast cancer patient, but she has helped to raise funds and to help train some breast cancer patients. Her name is Stephanie. She's a personal trainer, and I'm getting back on the wagon. So Steph, if you're watching, next week I'll be at boot camp. And it's important to have those types of friends and those people in your network and in your circle,
Yeah, we know Tiger Lily's doing a kind of workout or something every day, ballet dancing and everything. So
yes,
great.
It's all good. It's all good.
That's great. Ricky, what do you say we bring in a couple other friends here to kind of start talking about some of these clinical scenarios and how they've changed? Are you okay with that? You want to take some questions from the viewers while we bring on a couple of our Mocha Doc friends?
Sure.
Okay. Well, we're going to have Ricky take some questions, and we're going to bring her back. But I want to introduce two friends of mine. The first is Dr. Kathleen Laveau. Dr. Kathleen Laveau is a medical oncologist, so a doctor who treats cancer with medicine. She is in Atlanta, Georgia. She's part of Georgia Cancer Specialists. Dr. Kathleen, how you doing? I've lost the sound here. I see you, and I can read lips, so I heard you say I'm okay.
I'm okay.
There you go. I can see you and I can hear you. It's a good day. Hey, girl. Hey.
Hi, ladies. Thank you for inviting me.
Absolutely. I'm gonna have you tell more about yourself in a second, but we're gonna bring on Dr. Laura. Dr. Laura, would you come on the screen for us?
Hi.
That is fantastic, and we're going to get your name up in just 1 second. But Dr. Laura is a radiation oncologist. There we go, Dr. Laura Bonner-Millar. Did I say that right, Millar?
You sure did, yeah.
Fantastic. She is a radiation oncologist, so a doctor who treats cancer with X-rays or radiation. And I wanted you both to, one, I'll let you introduce yourselves and talk about your practices, but two, maybe talk about some of the changes in your treatment algorithms as a result of COVID. So Dr. Laveau, would you like to start?
Sure. I'm originally from Brooklyn, New York.
Brooklyn in the house.
Exactly. Brooklyn is in the house. I did all my training in New York. I've been a hematologist and medical oncologist for over 10 years. And I worked in New York and then moved down to Georgia with my family and practiced here with Georgia Cancer Specialists, and have been with this group for over 5 years. And there are over 30 oncologists in this group here in Georgia. So it's a pretty big group. Mm-hmm. And we've seen a lot of changes more recently because of this pandemic. Mm-hmm. And I'm glad to be able to talk to you all about it this evening.
Fantastic. Dr. Laura, you want to fill us in? Tell us about yourself.
Yes, I'm originally from right outside Baltimore, Maryland, and mm-hmm. I did my residency at the University of Pennsylvania in Philadelphia.
Hey, Philly!
Philly connection. And I currently live in Virginia Beach, and I've been practicing down here for 8 years. I'm on faculty at Eastern Virginia Medical School.
Fantastic. Well, Dr. Laveau, let's start with you. Jersey mentioned that she was not able to get her Xgeva shot, and I wonder if you could tell us a little bit about Xgeva and what the lifespan of it is and how long she can go. She said she didn't know when she could come back and if it was okay and what was happening to her bone density. So maybe let's just start there and then get into, some more conversations.
So Xgeva is given to patients to strengthen your bones if you have any metastatic disease of the bones or, in your case, breast cancer that has spread to your bones. So Xgeva is in the class of what we call bisphosphonates. It's a bone strengthening medication. I think it's important to have a conversation with your oncologist about it because we can give it monthly, but it can also be given every 3 months in some settings.
Okay.
So sometimes people, I often transition patients from a monthly injection if they've been on it for a very long time to every 3 months. So having missed your Xgeva maybe for a month will not have any negative adverse outcomes.
Okay.
But it is important to have that conversation with him when you get back. Because there are certain things that we also monitor your calcium levels when you're on Xgeva before giving it. And so we look at all your labs before administering it. You have to be taking calcium and vitamin D along with it, and you should be doing that also anyway. So I don't think that missing it for a month will have any adverse outcomes at all.
No one ever told me to take vitamin D.
Oh, really?
And any ideas on a starting dose?
So usually I tell people to take 800 international units and 1,200 milligrams of calcium daily.
Okay.
And so it's interesting because a lot of times I do check my patients' vitamin D levels. A lot of us are vitamin D deficient.
Right.
And it's important to have that repleted if you are.
Right.
But baseline for just normal bone health, it's important to take calcium and vitamin D.
Okay. Thank you.
What are some signs of vitamin D deficiency if somebody was worried about that?
More commonly, fatigue. A lot of times when we're fatigued, it could be a lack of vitamin D. And, and especially with being indoors most of the time, we don't spend a lot of time outdoors here in the US. And a lot of people, believe it or not, are vitamin D deficient. And so fatigue is more commonly, if you go to your primary, you complain of fatigue, it's usually one of the things that we now know to draw and replete if you can. But yeah, you should have a conversation with your doctor about that, Jersey.
Okay, I will. Thank you.
I love that. Now, Jersey, you've been taking patients to radiation too, right?
Yeah.
Are they able to get your radiation treatments, or are some patients not getting radiation right now? Have they been postponed?
They're still getting their radiation.
Okay, Dr. Laura, how's radiation going for you and for some of your patients? Are you finding that things are business as usual?
Well, not exactly, actually. So there are some women who are self-electing to defer their treatment, and there are some who are foregoing radiation altogether. So we've known for a while that there are certain groups of women with really favorable cancers, usually the stage 1s that are hormone positive, who after having a breast conserving surgery don't necessarily need radiation. And so those are the women who are more carefully looking at, okay, now that we've added the COVID on top of it, is that risk benefit ratio really there? Right. So a lot of those elderly, I'm not talking about young women, I'm talking about the women typically age 70 and older, are actually choosing to omit the radiation and do endocrine therapy alone, which is actually totally acceptable. Even prior to COVID, but that just has kind of given more weight to that recommendation. Okay. As far as women who we need to treat, there are definitely women who we absolutely need to treat. And we are very concerned with minimizing their exposure as they come into the office. We don't have any way of knowing exactly who has COVID or not. Asking about symptoms and temperature checking, we do that every day, but there's obviously a lot of asymptomatic carriers. And so for that reason, we are trying to shorten our treatment courses to the extent possible. So we have been doing that in the United States. That trend has been evolving, but we're doing that even more right now. So I do have some women who are coming in for only 5 treatment sessions. And then for locally advanced, we're cutting that down to about 3 weeks in May.
Got it. And so how do you decide? Are you doing any molecular tests or anything to decide, or is there like another algorithm that you use to decide who gets radiation and for how long? Is it based on the tumor size or other things?
Yeah, so it's based on the stage, right? So to do the very short course, we're talking about the 5 day, et cetera. That's usually our early stage patients where we're not treating the lymph node, where we're doing something called partial breast radiation therapy, because it's a smaller area. So it's safer to give a high dose when you're doing it to a small area without having more severe side effects than one would find acceptable. Um, Also, for our metastatic patients, we are looking at shortening the course of radiation as well, depending on the location where it may be technically feasible to do a higher dose per session over a shorter number of sessions.
I'm going to stop you guys right here and ask everybody who's not speaking to put your mics on mute for a second. And let me see if it stops the reverb, because there's a little bit of a feedback and an echo that some people are commenting on the feed. So Dr. Laura, I want you to, can you talk a little bit more about the window of time for which a patient has, like how long do you have to get radiation? Because I know that we have postponed some of our radiation due to COVID in New York. I think in places that got hit really hard, they pushed it back maybe 1 month, maybe 2 months, and they're kind of taking it as it goes and waiting to see how it goes. So what are your thoughts on how long you have to get radiation after a lumpectomy or breast conservation?
Right. So traditionally, most of the studies have looked at initiating radiation somewhere between 8 and 12 weeks. So, the data that we have for the most part supports 8 to 12 weeks after. However, there are some studies that also look at up to 20 weeks. So I think it really all depends on the exact situation. So again, in the hormone positive patients who are going to be taking an endocrine sort of therapy, I am not as worried about that delay because it's not like they're not getting treatment. They are getting an effective anti-cancer treatment, even if the timing has changed. So, as opposed to often we are going from doing the lumpectomy, then after healing to the radiation, and then the endocrine therapy, we're sort of flip-flopping it. And I don't think that there's any reason to think that the outcome should be worse because of doing that. Now, there are some patients who we really can't delay for various reasons. So, for example, if we have a woman who's had neoadjuvant for triple negative and she's had her surgery, and we really can't, if she's locally advanced especially, we really don't want to reduce that window. So everything's on a case-by-case basis. So there's some people that we are saying, yeah, we got to go get this done, but we're looking at how can we cut down the number of treatment sessions. So for locally advanced, wherever possible, like I said, we used to do somewhere between 5 and 6 weeks, and we're trying to cut that down to about 3.5.
Wow. And is that on a clinical trial basis, or is that like part of a registry, or is that kind of okay for standard of care?
Yeah, that actually has been studied in Asia and Europe, and there have been papers out published about that. And so that's something that the US is actually looking at in a randomized fashion, but the published data is from Europe and is from Asia, and they do not suggest any increased risk of toxicity. So this is just kind of giving us the impetus to go forward with that regimen.
Got it. I'm going to ask Dr. Laveau if you would chime in on neoadjuvant. So what does it mean? And are you seeing an uptick in patients being referred to you for neoadjuvant during COVID? Have you seen that happen?
So neoadjuvant therapy is systemic therapy that we give, or chemotherapy. So any systemic therapy is usually given to decrease the risk of recurrence, but specifically neoadjuvant therapy is given in order to downgrade someone's stage and make surgery a little bit easier, to make the cosmetic outcome a little bit easier when somebody has surgery, and to basically shrink someone's tumor. So we would give chemotherapy up front prior to having surgery. And that's for people who have a non-metastatic disease, people who have locally advanced disease. And so in this pandemic, I see that a lot of neoadjuvant therapy being given just because we haven't been able to perform the surgeries that we've been wanting to, because the ORs, the breast surgeons, are not able to perform the lumpectomies or that was scheduled to happen. So people will come in and have neoadjuvant therapy, not so much because it wouldn't have otherwise been planned, however, because it's only given in the non-metastatic setting. So it's someone who is looking at probably having a lumpectomy anyway, and we've had a conversation about having chemotherapy up front, some of their chemotherapy up front. What has happened is we would usually look for response during the neoadjuvant therapy, and then have a conversation with the surgeon about whether or not this person has had a great response, because it's given stepwise. So after the first step, let's say they're giving a combination of adriamycin and Cytoxan for a few weeks. You look at the response, speak to the surgeon if they had a great response, and speak about when would be the best time to have the surgery. Especially if someone's having unwarranted side effects from having chemotherapy, sometimes we bring in surgery a little bit earlier and then finish the chemotherapy later. But now, since surgery hasn't been readily available, we're just completing all the neoadjuvant therapy up front most of the time because of the delay in having surgery.
That's really interesting. I think I've been fortunate that I practice in an area. So even though I live in Philadelphia, I practice in a suburb of Philadelphia where they've not been hit terribly hard by COVID, thankfully. And
Right.
we have still been able to do a good deal of my cancer operations. But the reasons why, for the viewing audience, why surgeries are being postponed or delayed are because one, there's a very virulent virus that's going around, and two, the hospital resources that it's taking to care for those patients. So in places like New York and previously Seattle, you might even have patients who are on ventilators in the PACU, in the operating rooms, and other places. Like, you need all hands on deck to manage the epidemic. And so we have not been doing surgeries, and we've come up with a way through consensus guidelines and, with radiation, with medical oncologists, to figure out who to triage and how to proceed. So some people are going to get urgent surgery. Some of us are going to get medication beforehand, either pills or IV. And so I've seen an uptick in neoadjuvant hormonal therapy or endocrine therapy. Can you explain what that means for our viewers?
Right. So patients who are estrogen receptor positive and have a breast cancer are a candidate for what we call endocrine therapy. And that can be in the form of, many viewers may know about tamoxifen. And so that's usually what's used. And so I'll give an example of a patient who was diagnosed with a stage 0 breast cancer, or what we call the DCIS, or ductal carcinoma in situ. So usually that person would undergo a lumpectomy, then have radiation, then be put on endocrine therapy or be put on tamoxifen. And this person, this is a friend of mine who resides in New York, had what we call positive margins or needs a re-excision. And so since that can't be done right now, because like you said, the resources that otherwise, the surgeons would use are being used up by other areas because of COVID positive patients. She's not able to undergo her re-excision. So since she's not able to undergo her re-excision, they're placing her on tamoxifen, not because she wouldn't otherwise have been on tamoxifen, but because there's been a delay in her having her re-excision and then going on to radiation.
I'm going to ask. Go ahead, please.
So that's an example where we would use endocrine therapy. If you're estrogen receptor positive and we can't go on to surgery, endocrine therapy is also used in people who have locally advanced breast cancers and who can't have their surgery up front. And that is acting on your tumor, even though it's some sort of systemic therapy that's acting on your tumor, even though you can't have your surgery right away.
That's what I've been explaining to patients too. I think some patients feel like, in Jersey, maybe you can chime in here, Kathleen, I'll put you on mute for a second, is that, they don't necessarily understand that they're going to get the same treatments anyway, so that the sequence of things might change, but the treatments themselves don't. So we can do testing and we can know if you're going to need chemo on the back end after surgery, then I can give you your chemo before surgery. If we're going to put you on a pill after surgery and radiation, then, if your tumor is large or it's not safe to do surgery, then we can start you on that pill ahead of time. What's your sense of what patients understand about tamoxifen or estrogen blockers? And, do they understand the course of treatment when they get back in the car with you, or are they just kind of, deer in headlights?
Most of them are deer in headlights. Because I was on tamoxifen, I can speak to them about that. I actually never did traditional chemo. I did tamoxifen, I did Faslodex, Xgeva, Ibrance, and now I'm on Verzenio and Letrozole. So we do talk about the treatments, and sometimes they don't understand. One patient today, she said she needed 4 rounds of chemo, and if the 4th round did good, then she wouldn't have to do any more. But if not, then she would need 2 more. But she doesn't really understand that. What's gonna determine, and I'm assuming it's if they see that the tumor's shrinking.
Mm-hmm.
And another patient, she had a mastectomy, and she said she didn't even get to stay in the hospital. Like, she had the surgery and they sent her home. And I told her that that was probably better for her because the hospital isn't a great place to be right now. Even though Charlotte, North Carolina has a high rate of COVID, but not as high as someone else. But the hospital just isn't a place to be right now.
I think that's, hang on, let me, there we go. Can you hear me?
Yes.
I think that's a really important point that you made, because we are now starting to do what we call enhanced recovery pathways. And so some of our patients do go home same day, and it's not, you're not getting shortchanged for what you should do. I think we got to treat every patient sort of on an individual basis. So when I do a mastectomy, usually my patients will stay maybe 1 night in the hospital and go home the next day. But when we have ways to manage pain, and we have nursing set up to meet patients at their homes the next day, and when all the right things align, we're able to send patients home same day now, after their surgery, and it really is remarkable. So I think that we're more likely now to sort of start using those pathways because we know they work. We know they're safe because we do want to get patients out of the hospital. And somebody asked that question, does surgery put you at a greater risk to get COVID? Does chemotherapy, does being a patient who's getting radiation, does that make you immunocompromised? You guys want to weigh in on that and whether or not it makes you more susceptible to COVID?
I don't know that it necessarily makes you more susceptible to COVID, but we know that people who have pre-existing medical conditions have worse outcomes if they are affected with COVID. So there's a lot of fear and anxiety right now, especially if you're immunocompromised. We have a lot of patients that don't want to leave their homes. We have a lot of patients that want to delay treatment. We have a lot of patients that don't want to come into the office. I mean, our doors are always open. We treat people every day with chemotherapy because we don't want to stop someone's treatment, especially if it's if it's going to lead to a cure, right? If it's so people are always very apprehensive. So we've now have, unfortunately, a new norm of doing Instacart, like Jersey mentioned, instead of shopping in the stores, about doing telehealth visits instead of coming into the office. So a lot of it is about your level of the patient's level of comfort also. So we've done telehealth visits. I have a lot of patients who still come into the office for their Xgeva injections, or if they have a Faslodex injection, like Jersey mentioned. We have patients that come in every day for chemotherapy, but we also talk about taking the necessary precautions, not only in the office, but when you're at home. We ask people to stay home and do what you're doing, Jersey, doing Instacart instead of going into the stores if they can. We take temperature at the door. All our patients wear a mask throughout their whole visit in the office, and so do all of the providers, including the front staff in our office. Everyone is wearing a mask. So if you're there to get treatment, you're going to wear a mask the whole entire time that you're there. And even if you're coming in for labs, we no longer have any visitors coming into the office for that same reason. But there's still a lot of fear and anxiety. People don't want to be admitted to the hospital because of the fear of contracting COVID. And with reason, no one, even if you're a healthy person, doesn't want to have to go through that. And so much more so someone who's going through any sort of chemotherapy right now. So it's also difficult for people because they're not able to bring their family members. I tell my staff that, a cancer diagnosis is such a difficult one to deal with, that once you're given that diagnosis, most people retain 10% of what you say
Right.
because you suddenly go into this space where you hear nothing else but that one word. So it's up to us to really educate. So I always carry a highlighter in my pocket. My nurse always has a highlighter for me because as I talk, I kind of draw and I highlight because I want you to look back and be able to remember the important things that we talked about. So
That's
whether it
good.
be your stage, your pathology, and you also have to be able to go back home and explain to your family. So
You're
luckily
absolutely
now,
right.
So luckily now we have telehealth. When we can put family members on the phone, or if we're having a telehealth visit, family members can be on the phone and they can listen in on what we have to say. But one of the things I like to do is print out the National Cancer Guidelines, and I go through a whole pathway and the whole algorithm of what we have to do. And I ask my patients to write down all your questions so that the next visit, because that first visit, no one knows all the right questions to ask. But that
Right.
next visit, you should have a whole long list of questions. You leave my office with actually a binder that has a notepad in it. You come back with that notepad with full of questions so that we can discuss anything that may be bothering you, or any questions that you may have, if it has to do with your stage, your treatment plan, medications, what chemotherapy agents, side effects. You should understand every step.
And I really like that, because when I have the patients in the car, once they leave the appointment, I always talk to them. Like, I ask them, do you have any questions? Do you understand this? Are you able to tell your family? And then I'm like, make sure you show your family that piece of paper, because I'm not going to be there with you.
Right.
You know, write down everything you need, because
Right.
the funny thing about what I do is some people, they can go by themselves, but some of the patients, I feel like, and I call them vidas. I don't call them patients. Vidas means life. And I'm like, I can't believe their family is just sending them with me. And I mean, you know, and I feel like I want to call them afterwards, but you know, I'm like, that's their personal, private information. And I have to explain to the nurses, they're Caucasian, and I'm like, you know, sorry, but it's different in the African American community, and this is just how it is. Like, they think I'm their granddaughter.
Well, you know, we're all cousins anyway. But Dr. Laura, I want to get you in the conversation, and it's true. You know, I've had a lot of patients who will bring their entire families, and you know, this is. It can be a community effort, and sometimes patients don't want to tell anybody. And this is where we really need to stress the importance of having advocates and being as open as you can be with your family members or your primary support. Because if you come by yourself and you go through this process alone, it is even more isolating, and you may have challenges that you know you need to communicate with someone. You may miss information. So for people who are out there who are going through this, find you an angel, find you a Jersey, find you a cousin, who's been through this before. If you're not comfortable talking to your own family about it, because no one should have to go through this alone. Dr. Laura, I want to ask you about radiation and the immune system. People are saying that cancer patients are higher risk for COVID, et cetera, and they're trying to boost the immune system. And I wonder if you could weigh in and talk about whether or not and how radiation has any effect on the immune system, if any.
Yeah, so when you get radiation, there is an effect on circulating immune cells and blood cells. But for the most part, the major producers of our blood cells are our bones. And so if we're not radiating the bones or a large portion of the bones, the effect really should be minimal. So most patients who are getting radiation therapy alone, we don't even check their blood counts typically, because the radiation doesn't have much of an effect. However, the cancer process itself, right? It is thought to, the whole shebang is thought to kind of be a patient thought to be at a generally immunocompromised, even if we can't necessarily quantify that. That is a risk factor for a negative outcome. So I always tell my patients to exercise, their extreme caution, and they are wearing the masks in our office, and we're all masked as well.
Mm-hmm. Absolutely. Are there any things that you're recommending from a nutritional standpoint, either of you, to help patients boost their immune system, or things that they perhaps should stay away from, especially if maybe you have metastatic breast cancer? There's certain foods or certain supplements that maybe to consider or not consider? And I know that's a topic for an entire conversation, a whole show on nutrition. And we'll get there one of these shows probably in the coming weeks. But just if you had any fast tips or anything, or things you didn't want patients to do, things to completely avoid. Okay, didn't mean to stump you on that. I know, because we sea moss, we see cauliflower,
Yes, a lot.
turmeric. There's a magic
Yeah.
something every now and then that circulates, and it's like the cure-all for everything.
Right.
And
Right.
there are foods that can boost the immune system, but I wanted to know from the docs if there were any things that they said especially to do that were going to really help that immune system during this time. And the answer is just general good nutrition, I suspect,
Yes,
right?
it's general good
Yeah,
nutrition.
general good nutrition. In
Mm-hmm.
terms of antioxidants in general, we ask patients to not take high dose antioxidants during radiation. Why? Because
Tell me, yeah.
radiation depends on the presence of oxygen to do its job. So there's no randomized study to say what's going to happen if you take your antioxidants if you don't. So it's really more of a theoretical concern. So I really tell patients not to do any sort of special diet or go get any sort of unnecessary vitamin infusions while they're doing their radiation therapy.
I struggle with this one because I do advise my patients to boost their antioxidants to get rid of cellular damage. Antioxidants are the Pac-Mans that chomp away at cellular damage that radiation creates, that chemotherapy creates, that surgery creates. It all creates damage to cells. But there actually was an article that just came out recently, I want to say in JAMA, and Dr. Kathleen, I'll try to get it to you, but it talks about whether or not antioxidants are counterproductive for patients who have metastatic breast cancer and who are getting chemotherapy, because again, we rely on the power of the medicine to damage the appropriate cells.
Right.
And so if you are depleting the the fire that's fighting the fire, then what are you really doing, and are you going to see the benefit? And so it's a conundrum there, because I've always told my patients, lots of blueberries, blackberries, raspberries, strawberries, citrus fruits. But I think that's really good advice to consider that radiation relies upon oxidative damage and oxygen, and so does chemotherapy to some degree.
Yeah.
So
I usually advise my patients to have a healthy diet, but nothing. So sometimes people will come to me with a whole slew of vitamins or things that they're taking, and I have no idea how these things will interact with our chemotherapy agents. We just don't know. So I always tell people that just to err on the side of caution, because we don't know what drug interactions they will have, sometimes it's not such a good idea to mix things that there are things that I have no idea what they do. And a lot of times, I think the patient doesn't either, but they take them because someone has told them that this may help. And I don't, and we just don't know all that information. I wish we did. I wish
yeah.
we did have some sort of somewhere where.
Are you still able to hear me? I think that we have we've lost Dr. Kathleen. It might be a connection issue. But Jersey, can you hear me okay?
I can.
I can hear you.
Fantastic. I think we're going to bring Ricky back in, but I wonder if you have any words of encouragement for our viewers or any advice, especially on how to get the most out of your teleconsult. You said you had one and you didn't really mind, right? Everything went okay for you. But for people who are maybe a little bit nervous about that, what are some tips for them as far as how to do a good telehealth visit?
Ask a lot of questions, and I felt like that visit was longer than when I actually go to the doctor. I got to ask her more questions. I got to, keep her on the phone a little bit longer, and I felt like she answered all my questions. Whereas when I go into her office, I'm always like, I feel like she's rushing me. I don't know. Sometimes I feel like I need a new oncologist, but that's a whole nother story. Yeah, I felt like she's rushing me. So on the phone, I really felt like she took the time and we really talked about my scans. And maybe it was because it was my first scans after, being diagnosed with liver mets.
Mm-hmm.
So advocate for yourself. Don't think a question is too dumb or, you don't have the right to ask it, because it's your body and it's your life. And you have the right to ask about anything you want.
Mm-hmm. Yeah, that's great advice. I want to thank you for the work that you're doing. It's
Thank you.
incredible and amazing. Thank you for sharing your story. How can people follow you on social media? How can they support you? How can they send you donations? What can we do to try to get the word out for your organization? Tell us again the name of it and where we can find you.
The name is Angel in Disguise Inc. And my website is angelindisguiseinc.org. My Instagram and Twitter is angeldisguise_, and Facebook is Angel in Disguise Inc. And I thank you so much for having me today.
Thank you for joining us. We're going to bring Ricky back in, Ricky Fairley. And let's see, we have some questions and some comments from our public. So somebody said, I think it's hard to say good nutrition because many people have no idea what that means. So plant-based is a great starting point, but we also need to consider that, patients who are undergoing cancer treatment need a balanced diet. So lots of lean protein. They need their carbohydrates. They need their plant-based. They need, a balance of everything. And so to the person who commented about how we should know nutrition, I think that we do, but in the context of how certain supplements interact with medications, supplements are not regulated by the FDA. Nobody can tell you how many turmeric pills you need to take in order to decrease inflammation. That's sort of a broad kind of blanket statement. And so, we have to be careful that we don't cause damage to certain things. For example, I had a patient who was taking several herbal supplements, and they began to affect her liver. And the liver metabolizes a lot of the chemotherapy. And so if your liver is damaged, then the effects of chemotherapy stay around longer in your body. And so by taking the supplement, she thought she was doing a great thing for her health, but didn't realize that she was doing damage to her liver, which caused the chemotherapy to stay in her system longer. And ultimately, she developed liver failure. And so we have to be very careful that there has to be a balance between nutrition, and we get the majority of our nutrition from what we eat. So you take a multivitamin, you might get 30% of whatever's in that vitamin, and the rest goes into the urine. And so we have to really be careful about what we take in and talk to your doctors about how it could interact with the other medications, because it's not all about just what you put in, as far as your diet, but how does it interact with your other medications? So that's my soapbox. And so, Ricky, what you got for us? I think we're not able to hear Ricky. Are you able to hear us? Not at this time. Doesn't seem like it. Dr. Kathleen, have there been any particular patient stories that you can recall during COVID that when you look back on this in your practice 20 years from now, you'll be able to say, you know what, that touched me, that changed my career, it changed the way I look at something. Any stories that's tugging at the heartstrings right now?
So there is a particular patient of mine who's an older woman who had a recurrence of her breast cancer, triple negative, after many years, who underwent a mastectomy and needed adjuvant chemotherapy. And she moved here to be closer to her daughter, but she now lives in assisted living. And during this time, assisted living is on lockdown. So the residents have to have all their meals in their room. They don't have any activities and are confined to their room. And she came to me prior to us going on lockdown and was ready to start chemotherapy. But once this happened, called me in a panic and almost in tears, because she felt that although she was already confined to her room, if she was treated, she felt like she would have this 14-day be on 14-day quarantine because she had left the building.
Mm-hmm.
And so it kind of tugged at my heartstrings, because otherwise this woman wouldn't be going through this. Her daughter would be bringing her to her appointments. It would be more comforting to her, but she's going through the journey all alone. And the question was, because she's an older person, of whether to delay her starting her chemotherapy for a few weeks. And so we delayed it for a few weeks and said, well, let's just see. And this was at the beginning. And let's just see what happens, because none of us knew how long this was going to last. And after a few weeks coming back to see me, she says, I don't know, what if this goes into the summer? Maybe we should just keep starting, and we'll just call my daughter, and I'll, her facility was providing transportation, and she was able to come to her appointments, but she's still going at it alone. And it's a little bit sad.
Yeah. How about you, Dr. Laura? Anything that you're seeing right now that's, changing the way
Yeah.
you think about practice,
I mean, I think we are definitely evolving, and I think it's going to be interesting to see how much telehealth stays after all of this is over. Um, I've had patients who are very grateful that we were able to do video consults with them, and they've had their family members in the background and things like that. So I'm hoping that we'll be able to retain the good pieces of the innovation that come out of this. And some one thing that kind of made me a little bit sad is that, traditionally, at least in my office, at the end of treatment, patients ring a bell to kind of celebrate, having finished. And a lot of times patients kind of consider that like an event, and will have family members and friends and like all kinds of cheering, balloons and whatever. And now we're unable to do that, for their safety. They're ringing the bell by themselves. I mean, we're there, but they're not having all their family and friends, and it's not quite the big party. So we've had to transition that to, having it on FaceTime if they have a cell phone, or taking pictures of them or a video of them ringing the bell. But we still try to, on our end, still celebrate them and let them know that, we appreciate them.
Yeah, for me, I hug my patients. I probably I hug at the beginning of the visit, I hug at the end, and if we're having a difficult conversation, we might hug somewhere in the middle. And I miss hugging my patients.
Yes.
I had a patient who, when you go into surgery, it's already scary enough to have cancer, and now you're going into surgery, you can't bring anybody with you. And you may have to stay in the hospital overnight by yourself, and somebody who drops you off and picks you up. And I had a patient who said to me, in the pre-op holding area, she said, Dr. Gary, she says, I couldn't, I couldn't bring my family. And she looked at me and she said, so I guess that means you're my family now. And in my family, we pray. And she said, so would you pray with me? And we did. And, I always ask patients, what kind of music they like. And I'll try to do things that help to make them feel at ease. And so, the relationship between the doctor and the patient, I think this is a great opportunity to restore some of that personal touch, even through telehealth, even through just spending more time on a teleconsult, through answering more questions. I'll be glad to hug again, but it's been nice to see some of my patients learn to use Zoom, learn to use FaceTime, and get their families involved in ways that they might not have before. So I think you're right in that, something positive can hopefully come out of all of this. We might have new protocols. It didn't take 20 years of research to develop because of this virus, and we can see what works and we can move forward with it, and I think it's gonna do some major things for medicine, the ability to have telehealth. I'm waiting for Ricky to come back on, but she asked us if we would talk about what to do if someone feels a lump. So if a patient feels a lump, are you guys prescribing or ordering imaging for them? And what are you counseling if a patient comes in and says, or if they call you on their television, say, what, I got my scar tissue here, but I'm feeling a lump. What do you recommend?
Well, usually I would have that person come in because they do need to be examined for us to determine the next step. I think that especially if someone has a history of breast cancer, any changes to their breasts is oftentimes very anxiety provoking. So that needs to be addressed. Unfortunately, a lot of our radiological facilities have been pushing some diagnostic mammograms back. So some people, and getting screening mammograms pushed into May or June for people who would otherwise have had it. For diagnostic mammograms, we can probably get that done sooner, but for screening mammograms, absolutely not. So if somebody feels a lump, they come in, they're examined, and we order a diagnostic mammogram, and we make a phone call that can alleviate their concerns, especially if it's something that's concerning to you on physical exam.
Yeah, I agree. Yeah, I've been ordering imaging, diagnostic imaging. Yes, screening imaging has been postponed.
Yes.
Because there is an opportunity to do that later, 1 month from now, 2 months from now, 6 weeks from now. Insurance still pays for that. And so the benefit of screening versus the risks of, catching a contagious virus right now, the benefit outweighs the risk. But I absolutely agree with you. Let's see. We had some other questions here, and I know that I know that Ricky is going to log back in. Let's see, hormonal treatment. We talked about surgery and radiation. And let's see, how about vitamin D? A patient with MS is wondering about vitamin D. Is there any comment that you can make about that?
I think there's a lot of benefits to repeating your vitamin D level if your vitamin D level is low, even in terms of how you feel. But I don't, a lot of the multivitamins that we take do contain vitamin D in small amounts. If you're
Mm-hmm.
vitamin D deficient, sometimes that actually requires prescription to refill your vitamin D levels, and then to have your vitamin D levels repeated to see whether it's in normal range. So whether we realize it or not, the multivitamins we take, most multivitamins have calcium and vitamin D in them. It's
Mm-hmm.
just usually not enough if you're vitamin D deficient.
Sure. Yep. And one of our viewers has been commenting on the benefit of an alkaline diet and some alkaline foods as well, garlic, ginger, etc. And I think that, part of a multidisciplinary cancer program now is offering patients the opportunity to talk with a nutritionist, to look at their diet and to set those goals. And, I do spend a lot of time talking with patients about their diet and the food that they should eat and how they should exercise and safe exercises to do during their treatment. And so I think, having a very integrated and balanced approach is definitely important.
Absolutely.
We did have one question. Somebody said, are you suggesting at this time that a patient should bring all of their records to every doctor appointment?
No.
And well, if you say no, then I need to know why, and if it is a patient who's in your health system or not, because that's a different story, I think. Like if they're coming for a second opinion, a new consult, your medical record is from some other hospital, then yeah, I want to see it all. But if you're already in our system and you're coming in to discuss your surgery or after chemotherapy, what's the best way for patients to keep track of their information, I guess, is probably the real question. But let's start with the question.
Go ahead.
So I would say if you are getting all of your care within one particular health system, you don't need to bring that information. Your physician can look that up in the electronic medical record. But there are plenty of patients who get care at different locations for various reasons. So personally, what I do is I actually review every new consult before it gets scheduled.
Mm-hmm.
So I look and see, do I have all the records I need already? Or is that something that we need to try to get?
Mm-hmm.
And so if there is a question, we may call the patient and say, hey, do you happen to have this XYZ thing? Or you have your old records from whatever. Or if we cannot obtain it on our own, because sometimes, unfortunately, come to sign a waiver first. We can't necessarily always get it directly. So yeah, I would say unless your physician has or the office has directed you to bring your records, that you're probably good to go.
I would agree with that, and I think it is good to definitely take notes and also to have done a little research. I don't mind when patients do research at home. I would rather you bring me what you read so that we can go over it together and we can talk about, is this from a reliable source? Is this something that is useful to you? Does it even apply to you? I'll give you an example. I had a number of patients who came in asking about their oncotype scores after the results from Taylor RX came out, and there was a lot of marketing about it. But some of them were triple negative and HER2 positive, and I don't think they didn't quite understand, everything that was going on. So absolutely, bring it in. We can talk about it. We can go through it, and we'll go through it as many times as we need to. Let's see. Any other thoughts or comments? I think we're going to get ready to go through, but I want to make sure that we address everything in terms of the changes and how do you see things getting back to normal. So my question for you, Kathleen, is this. If patients have been placed on neoadjuvant, do you see it through to completion, or are you guys taking it sort of based on the clinical response and then maybe stop? And will you resume after surgery, or do you just, if they're scheduled to get, AC and T, and then, I guess the question is, once they stop their chemo, go to surgery, are they then obligated to complete that course? If they're on neoadjuvant hormonal therapy and taking an estrogen blocking pill and we're able to do surgery next week, do we go to surgery or do we need to see that through for 6 months or whatever? So how are you counseling patients to sort of reintegrate back into their healthcare after COVID?
Well, I think it's on a case by case basis. It depends on the person. So here in Georgia, we're supposed to be opening up next week. So a lot of cases are going to be put back on and scheduled. Some, of course, some cases were continued anyway. Anything that wasn't elective was continued. Things that were elective were put on hold, and some people who are waiting to have their surgery are going to be able to schedule that. But in terms of neoadjuvant therapy, I think it's based on the person's response. Sometimes, we start neoadjuvant therapy and and the person doesn't have the optimum response, and we would have to go on to T anyway after AC. And sometimes that person has had the best response after AC. Now, in this setting, since we haven't, since we haven't been doing the surgeries that we wouldn't otherwise, as many as we would otherwise do. If that person has had a great response to AC, it's not going to hurt them to do some T and then continue it after. So it hasn't really changed their treatment plan. It's just how many of them are they going to get before they go to surgery. I think that now, though, that the ORs are going to be opening back up, yeah, everybody who's been waiting to have their surgery done will be happy to have it done. Doesn't mean that you won't have to have adjuvant or treatment after surgery.
Let me
Hear you.
undo. So
There you
what
go.
determines, there we go. So what determines if they're going to need chemotherapy after their surgery?
Well, it depends on if you have any residual disease after surgery most of the time. I mean, for some people, if they've had some unwarranted side effects, that's from Taxol, and we've given the maximum of Taxol, and you have such unbearable neuropathy, we're not going to go back to Taxol afterwards. But if you're estrogen receptor positive, you would have had to go on to endocrine therapy anyway after surgery, right? So we would do that. So it hasn't really altered our treatment plan. It just altered, the sequence of things or how fast things are occurring.
Mm-hmm. And how about from a radiation standpoint? Are we going to see an influx of radiation now that COVID is over, or are you going to continue maybe doing the hypofractionation and the other shorter courses once things resume? What changes for you?
I think I'll probably continue with doing the accelerated partial breath a little bit more. But it really just remains to be seen. I think we are going to have an influx of patients who, because they haven't been getting their screening mammograms, therefore they haven't diagnosed. So I think that we are going to get quite a few breast cancer patients, the early stage ones, and also the ones who've been doing their endocrine therapy sort of as a bridge.
Mm-hmm. Absolutely. I think from my standpoint, we are going to start reintegrating surgery, and the way in which we do that and how we prioritize that, is challenging. I have a saying, cancer doesn't quarantine. And so, we've been very fortunate to try to keep pushing for surgery, especially for those who are the most in need of it. But we're going to make sure that we start taking care of our cancer patients again and doing more of the types of surgeries that we've not been able to do, especially with respect to reconstruction. So anybody who's been getting mastectomies has been getting a tissue expander. They might not have been getting their contralateral or the opposite side done because of COVID. So they may have only had one breast that had a mastectomy and the other one hasn't. And so we're going to make sure that we, complete those treatment plans for those patients and then get them to their reconstruction and, get them safely through recovery and on to whatever comes next, whether it's radiation, whether it's hormonal therapy, or, on to survivorship, which starts at day one. I see Ricky's back on.
Hey.
Hey, girl. Hey.
I went to the moon and back.
Ready to round it out. Did you have any last questions for us, or you want to? I want to get from these two lovely doctors how we can follow them on social media and how we can stay in touch and maybe ask additional questions, because I think after this you may find that patients have some questions they may want to ask you. So, Dr. Kathleen and then Dr. Laura, how can we keep in touch with you?
So on Instagram, I'm at Dr. Kathleen Laveau, and same with Facebook.
Okay. Fantastic.
You can find me on Instagram at Laura B, the letter B, Well, MD.
Fantastic. Well, thank you guys for joining us. Ricky, how we doing? How did it go?
Thank you so much. And you can also reach out to me on Twitter and Instagram at Ricky Dove, RICKIDOVE. Thank you so much for all the great information you gave us today. I guess I went to the moon and back on technology virtual land. But it's a great discussion. I was kind of listening on another vehicle, on another device. So thank you so much for all of your advice. I think that I was just going to, when I brought up the question about if you feel a lump, I mean, like if you're a new patient, feel a new lump, advocate for yourself, stand up for yourself, go to the doctor. Don't let COVID stop you from getting that checked out. We're also fearful to begin with about finding a lump. Don't let this pandemic kind of get in the way of standing up for yourself. And even I love all my doctors. I love you guys for everything that you do. If you don't feel like you're getting the right care from your doctor, call one of these ladies and they'll help you out. Because if you feel like you're not getting care because they're too busy or you don't want to do telemedicine or for whatever reason, call us, reach out, and we'll try to help you get the care that you need. But always stand up for yourself.
I think that's a really good point, Ricky. With telemedicine, we can reach more people than ever before. So definitely do reach out, do your homework. You can follow me. I'm on Facebook, Dr. Monique Gary. I'm on Instagram, Dr. Monique Gary, LinkedIn, and the Twitter, and probably soon a YouTube page. My goodness. It's more technology than I ever thought I would use.
Right.
Please do reach out. We want your stories. We want your questions. We want your feedback after this. We want you to share it with your breasties because we're going to keep doing this. The doctor is in, and we're going to feature more, particularly Black doctors, so that we can connect our patients, who may not see us, with the doctors who are in your area. We out here, and we are happy to take care of our communities. And yes, we are going to talk about prevention. To the person who put in the comments, why don't we talk about prevention?
Right.
Well, we're going to get into it. You better believe it, because that's where this has to start for us. It has to start with prevention. So the conversation
when Monique and I first started talking, I'm sorry to interrupt you.
Absolutely.
When we first started talking about this, in 5 minutes we came up with like 20 things we could talk about. So we have so much more to talk about, so many more episodes to share. So
tell them about the next episode. Who are we having on next week?
So next week we're going to have on my breastie, Mema Carmo, and she has a foundation called Tiger Lily, and she's going to talk about self-care. Okay. And now that we are at home, and I don't really think I have any more time. I think I'm working harder at home, right, than we were earlier. But self-care is so important, especially when we're doing so many things, have to take care of ourselves, have to take care of each other. So she's got some really great tips on how to care for yourself and put yourself first. I always say as a breastie, I had to learn from breast cancer that my peace is non-negotiable. And I'm still trying to find that peace, even in the craziness that we have, and we all need to do that. So we look forward to seeing you next week.
I love that. Absolutely. We will see you guys. Look out for the episode after that. My mantra is pleasure is not optional. So we're going to talk about sex, who's having it, who's not, how to get more of it, and what to do, with all these medications and things that are causing changes in libido. So we got some good stuff coming up for you. Invite your breasties, have watch parties, replay it, post it, because this is good information brought to you by blackdoctor.org. And we are so very thankful for this platform to do it. Docs, ladies, thank you so much. Stay safe. God bless you. And we'll see you next week, everybody.
See you soon.
Bye.
The doctor is in.
Bye-bye.